complaint, but we record that. When we record, what is important is the rapidity with which the temperature raises, produces a seizure. And at a particular temperature, these human beings start getting a seizure. And this was noticed very, very clearly. And repeatedly we did it, and then compared with a normal human being. And then it is all recorded, thereby showing that there is hyperthermia in these people which produces the seizure. That means what? Whether they have a febrile convulsions in the past. We looked at the history. 25% of our patients with hot water epilepsy had a history of febrile convulsion. And that was the history which we obtained. So we started now looking at this with rise in the temperature. Can we now do something about it? And this was the human experiments which we did. Aberrant thermoregulatory system in a susceptible individual which produces hyperthermic seizure. Possibly there is a kindling in the human beings also. The evidence is that they get non-reflex epilepsy as the time passes, which was not there. About 25% of them gets non-reflex epilepsy. So that means there is a kindling which is occurring, but nobody believes that there is kindling in the humans, so I cannot dare enough to say that there is kindling in the humans, but that is my own evidence here. But did we have any evidence for that? Yes, we did look at it. There are multiple factors which is responsible for hot water epilepsy. It is contact with the water, temperature of the water, the specific area of the stimulation, and repeated stimulation. These are the factors which are responsible for bringing the hot water epilepsy. We wrote a paper on trigger mechanisms in hot water epilepsy. At the same time, my colleague pathologist, Dr. Shankar, who was working in pathology department, looked at all his brains, and there were 4 brains of the people who had hot water epilepsy history. And then they have died for some reason. And when they died, their brains was with us. So we looked at 4 of these brains. As you can see here, these 4 people ages 15 to 53 years, and 2 are 12 years and 1.5 years. Duration was very long. They have type of seizures, and then they have died. 2 people because of the status epilepsy, and 2 others had incidental hypothalamic failure, one of the patient, post-operative, which I'm sure Dr. Mathaya would have been very happy to know. Post-operative hypothalamic failures are known to occur, and vertebrobasilar insufficiency. So we had the brains, and we looked at the brain in these 4 areas, thereby showing that there is a damage which has occurred in these patients with hot water epilepsy. Then we looked at EEG of these patients in 70 people, out of which 55 were normal and 15, that is 21.4%, were abnormal. We had from the literature, and these are the cases with a classical spikes and foci across the anterior temporal region, which is seen in these patients with interictal EEG abnormality. There is a series which has been published, and now from 1965 onwards, but ours is one of the large series. There are abnormalities in the temporal spike, and in the Western literature, even they have put the caps and water immersion in the bathtub. They have recorded and shown that there are left anterior temporal focus, left hemispheric onset, and posterior frontal region. There are spikes in these, thereby suggesting that there are definite epilepsies which are arising from the hot water stimulation, and it is in the temporal region. Then somebody had proven point saying that there is an abnormal brain in this. So can we look at it? So we started doing an MRI. An MRI of these patients were done. Majority of them had normal, except that there were 2 people with a bilateral MTS, medial temporal sclerosis, and 1 had a left MTS. These were the patients who had a long time hot water epilepsy. That means whether it is a consequence rather than the cause for the epilepsy. That means repeated stimulation has produced the medial temporal sclerosis in these patients. But we still do not know what is the cause. That means I need to know if there is no anatomical abnormality, there has to be a functional abnormality. So how can I prove the functional abnormality? It is easy now, because there are what is known as SPECT scan. Ictal SPECT scan can be done. So we went ahead and searched for where is it available in Bangalore at that time, and in ictal SPECT scan, and we started doing. That means I can take these patients and put a needle and then give a bath. And as the bath is given, we can record where the blood flow increases. And that is an ictal periictal scan. So we used ethylene cysteine dimer as one of the radiopharmaceuticals which could be used, and then did a SPECT scan on these patients with hot water epilepsy. And what is interesting is here, we have a normal EEG on this patient with hot water epilepsy, normal MRI here, there are no abnormality, but we did a SPECT scan, and what we shown is a normal interictal scan. Interictal scans are here, it is normal, but you can see the difference between this and this. You can see the difference between this and this. You yourself can see that there is an abnormality with hyperperfusion, showed a left medial temporal hyperperfusion in this area when the hot water epilepsy occurred in these patients when the bath was given. Again, we repeated some more patient. This is another patient who has got a normal interictal EEG and an MRI, thereby suggesting that there is no structural abnormality. These are interictal scan and these are the ictal scan. And what we are seeing is definitely was a left lateral temporal hyperperfusion. Thereby suggesting that there is a functional abnormality in these patients with hot water epilepsy occurring in the temporal area. And that is what we published here. The clinical and SPECT studies in the suggested temporal lobe as the seizure onset zone in some of the patients with hot water epilepsy. Then we thought that autonomic function should be abnormal in this. Otherwise, their thermal regulation will not be abnormal. So can we not do that? It can be done very easily. That means we need to demonstrate whether there is an abnormality in autonomic nervous system, which Mathai was very much interested in this area. So we started looking at that. We have the patients with epilepsy suddenly dying. That is known as sudden unexpected epileptic death syndrome, SUDEP, which we know that there are patients who have epilepsy, suddenly one fine day they found dead. And that occurs even in children, which is called cradle deaths or SUDEP, SUDEP. So what is the cause for SUDEP? One of the major causes they found is because of the autonomic imbalance in these patients with epilepsy. Do we have a proof on that? There are many variety of autonomic manifestations which is seen in epilepsy. So this is known, the gustatory, which could be cardiac abnormalities. These are all very well known in the patients with epilepsy. So we started looking at normal first, a cardiac autonomic function in a drug-naive, newly diagnosed epilepsy patient. We published this paper that there is definite interictal subtle cardiac autonomic dysfunction which occurs in patients with epilepsy, which is a very well-known phenomena, which we did it in patients with seizures. Then these are the maneuvers which we did, Valsalva maneuver, isometric hand grip test, then tilt table test, which Mathai was shown in his laboratory. And we have an autonomic laboratory in our own setup, and we did that, and we looked at the hot water reflex epilepsy. And thereby we showed that there is a long work. This is our objective was this, and we did this pure hot water epilepsy patients. We took 45 patients, hot water epilepsy with a spontaneous complex partial seizure, that means non-reflex seizure, 25 patients, unprovoked spontaneous complex partial seizure, 40 patients, and a healthy volunteers, 50 patients, and 50 subjects. And then we looked at them and conducted autonomic function tests, heart rate variability, blood pressure variability, baroreflex sensitivity tests. All these things we did in this group of patients. And then this is the 45 patients who had pure hot water epilepsy. And then we did that compared with a healthy volunteer. And various autonomic function tests were done. And all these parameters have been mentioned here, and statistical significance have been mentioned compared with the 45 controls. And thereby we showed that there is a heart rate variability in these patients, and there is a variation with the blood pressure, and there is a variation with baroreflex sensitivity. And thereby suggesting that in this cardiac autonomic function test, there is abnormality in patients with hot water epilepsy with an altered sympathetic vagal balance. That means there is an autonomic imbalance in these patients with hot water epilepsy, and that is resulting in the temperature regulation problem, and that temperature regulation problem leads to hyperthermia, and hyperthermia leads to seizure. But one other question we had, that question was, we were mentioning that there is a susceptibility. So we need to now, can we take this understanding to a patient and treat them? It is a very, very next question which we ask. So how do we treat? Can we now say, people were asked to say not to take hot water bath. Can you believe? If you can say that not to take hot water bath, it is like a person who is taking alcohol. Very easy answer. Stop drinking alcohol. I can preach 100 people. How many will accept it? They won't accept it because they get pleasure. Similarly, these patients, I said that they get pleasure out of hot water bath. That is a very, very difficult. Then the people were asked to say that don't bathe yourself, take a wet towel and rub the head. That is what that was the treatment which was given earlier. Then we were wondering, when I know there is a hyperthermia, can I use paracetamol or aspirin tablet? It doesn't work. You know why it doesn't work? Because they are normal temperature in the beginning. The temperature goes up within 2 minutes time and they get the seizure. So that doesn't work. But we have a model of febrile convulsion, where in the febrile convulsion, people are given benzodiazepines and they get prevented. Taking that cue, we started working on using benzodiazepines. And now we have all established, various experiments have been done. We now ask these patients to take one clobazam tablet, that is 5 milligram for children and 10 milligram for adults, 1.5 hours before taking hot water bath on the head on that day. And if they take it, they don't get any seizure and they enjoy the bath. And they have come back testing me, stopping the drug, and they get a seizure. And that is my proof here. An intermittent clobazam prophylaxis prior to head water bath might be a preferred mode of treatment. And only anti-epileptic drugs are required if they have associated non-reflex epilepsy. Otherwise, they don't require anti-epileptic drugs. And this is what now we practice. And this is a method of treatment which has been published. And this is the results there. And patients are very happy. They just take the tablet because most of them take the hot water bath once in a week, sometimes once in 3 days or once in 10 days. Those are the people, when they take hot water bath over the head, they take this tablet and they are enjoying their bath without any problem. And this was an understanding because of our animal model and developing. I need to prove another point, whether there is a susceptibility. Susceptibility individual means genetics. So that means, is there a genetics of hot water epilepsy? Do I have about 5 minutes more? Yeah. So I looked at the 304 patients with the phenotypic characteristics of hot water epilepsy, complex partial seizure with secondary generalization, and primary seizure. So we looked at it, these 304 people, and trios, that means the patient and the father and the mother, or the family history when it is positive. There were 67 people with the family history positive. Out of the 67, we had small family, that is 2 members affected, or 41. Medium family, there were 3 members affected, was 12. But interestingly, I had large family with 4+ people affected. But I was looking for these people where there is a strong family history of hot water epilepsy. So we started jumping at that. And this is the family where I looked at. I went to the village and collected all the family members' blood and also the pedigree chart. We have here 14 members affected here. And all the family members, starting from a 2-year-old child to a 94-year-old man who had the hot water epilepsy. We collected the blood sample, both affected and unaffected, and started looking at it. First thing what we wanted to look at is here a febrile convulsion gene. Whether, because this is like febrile convulsion, can I rule out a febrile convulsion genetics? We know the genetics of febrile convulsion, so we have the genes. That is called Feb1. Feb1 gene was looked for, it is not there, it was negative. Then we looked at Feb2, another gene that is negative. Then we did the third one, febrile convulsion gene, that is also negative. That means all febrile convulsion genes were not there in our hot water epilepsy. Then what should we do? There is no other way but to go for whole genome scan analysis. That means whole genetic analysis has to be done in this family, then only we can do that. So we started looking at the whole genome scan, and in this family, we have an association with 10th chromosome, 10q21 to q23. And this is the area which is the genetic abnormality which we saw in this chromosome, in this family. Then another family we started, haplotype analysis was done, and then we have a smaller number with 2 members and 3 members affected. We added their blood and looked at the larger families, and then we looked at that there is an additional locus. This was the locus at 10q21, q23 was the first association in those families, both with the large family and the small family. But we were not happy that this could be an association. Is this the single gene disorder? No. We started looking at, these are the genes which are available. There are potassium, large conductance, calcium activated channel, voltage dependent anion channel, solute carriers, and glutamate receptor channels are available in this area. So we started looking at it, and then we published that paper, and we next looked at another family, and this is a larger family with 7 members affected with hot water epilepsy. And in this family, we added few more families with the smaller families with 3-member, 4-member affected, and looked at the same 10th chromosome. The 10th chromosome was not available, and here there was another chromosome which is at the chromosome 4. And in the chromosome 4, at this area, various genes were there, and this is the area which was abnormal, and my pathologist, my genetist, looked at this gene carefully, and what we see here, there is a gene for partial epilepsy, there is a gene for familial medial temporal lobe epilepsy, and we have a gene in this area which is a hot water epilepsy gene. That means it is an epilepsy gene in that chromosome which is responsible for the hot water epilepsy. But we started looking at, can we have what is that gene? Is it possible to get the gene out? This is an association now. We started looking at the various families. This has been published now. And this is a family which is a larger family with the smaller families added together. And we looked at this gene. And there is another chromosome which is the 9p 24.3 to 23. This is the area which was abnormal, and this is a hot water epilepsy area in that particular chromosome. We have a epilepsy familial temporal lobe, epilepsy idiopathic generalized susceptibility in this part of the gene, and epileptic encephalopathy early infantile in this part of the gene. So this is the whole chromosome, which is a large one, and this area is responsible for hot water epilepsy. This region harbors about 60 genes, out of which 24 are expressed in the brain. So we started looking at it, and then we were lucky, and this is the gene which we could identify now. And this is the first time in India we are able to isolate the gene, and this new variant was not found in 540 control chromosomes from the normal individuals, and the gene is a transporter of glutamate at the pre and the postsynaptic neuronal terminal, and this is the gene. And this is a gene which we could identify, and it is a missense variation, and we are published in this family. And these genes are called SLCA1 or EAAT3 gene. And there are 3 types of genes which are available, and this is present in the neuronal somata dendrites but not enriched in the spine. And this is the gene which is responsible for hot water epilepsy. That means we have now a gene which has been responsible for hot water epilepsy, and this is a glutamate transporter receptor gene abnormality. So in summary, hot water epilepsy is frequently reported from South India, though had a worldwide occurrence. An animal model mimicking hot water epilepsy has been developed and demonstrated that these are hyperthermic seizure with kindling. It is a type of hyperthermic seizure in humans with a possible aberrant thermoregulation in genetically susceptible individual. Functional imaging has been done, demonstrated ictal abnormality in the medial temporal structure. Cardiac autonomic function tests demonstrated abnormality in sympathetic vagal tone, and then they can be managed using a prophylactic benzodiazepine just before having a hot water bath akin to febrile convulsions. Only those with a non-reflex seizure require AED therapy. I started my lecture saying that some people doubted whether such an entity exists or this is a functional phenomena. I proved the point, and at the end in 2004, the classification of hot water epilepsy has been included in the International Classification of Epilepsy now, and this is ILAE proposed classification which is included, and now this is there as a stamp of that the reason hot water epilepsy is a reflex epilepsy. And in the genetics, 12 to 27% of hot water epilepsy patient has a positive family history, and hyperthermic seizure first ruled out association with febrile convulsion genes. Whole genome scanning of the hot water epilepsy patient in large family yielded multiple association with 10q, 4q, and 9p chromosomes, thereby confirming that hot water epilepsy is a polygenic complex epileptic disorder. And exome sequencing yielded a gene which is known as SLC1A1, a gene, a glutamate transporter gene, which is responsible for this. So we still propose to do some more work, that is a receptor physiology, channelopathies, and I'm now got a PET MRI scan in our institute for the first time in the country, and we plan to use this and to look at PET MRI in these patients, seeing the abnormality, because we can directly see the radiopharmaceutical tagging on and then look which region is abnormal, and genetic epidemiology to look at which area, why they are more common in certain areas of the country. And this I owe it to my teacher, Professor K.S. Mani, who described the hot water epilepsy much earlier, and I only picked it up from him and started working on to find the answers, because it was considered as a doubtful entity. And here all the people, Dr. Gautam, who is a physiologist, was in MS Ramaiah College, who worked with me, Shankar, who is a pathologist, Anuranjan Anand, who is a genetist, Sanjeev Sinha, who is my colleague, who is working with me. This is Satyaprabha, who is a physiologist, who is working on autonomic functions, and these are my PhD and doctoral students who have worked with me to understand about the hot water epilepsy. And that is, I leave you with my flora and fauna of NIMHANS campus, and thank you for assistance.
Very rarely do you see signs of this order get translated to patient understanding in India. Please give him a very big hand. If there are one or two quick questions for Professor Satish Chandra, I see three hands go up, and that's it. Yes. We'll start with the lady.
I'm Sheila, pediatrician. I have just two questions. You mentioned that the youngest child was 2 years. Is there anything younger than that? Are there any signs and symptoms or that we can pick up?
No, we didn't have. We were looking for that even with the small children. We didn't have that. And Jai Kumar from Madurai, I think you must be knowing about him. He's a very well-known pediatrician. He had a child, even 8-month-old child. And he shows the video also in most of the places, because you know that how the Indian babies are given bath. The mother keeps their child in between their legs and pour the water. And the child had a seizure, and he has shown. I had asked him to give me that video, but unfortunately I didn't have. That's why I'm not able to show that. But he has shown even in 8-month-old child.
The second is, sir, I saw the large pedigree which you had projected. Is there any difference in the symptoms, severity, between children born to non-consanguineous and consanguineous parents?
No, we did see both consanguineous and non-consanguineous. That was another paper which we have published earlier, that I'm not bringing it out. We have about 30 papers on this hot water epilepsy itself, various spectrum. And earlier we did consider that this is a recessive gene with an incomplete penetrance. And that was our observation. This is seen more common in consanguinity, and recessive gene is the one which is responsible, but which is an incomplete penetrance. It is not complete penetrance. That has been published in Current Science earlier.
Thank you, sir.
Two questions here.
Thanks, doctor, for taking me down the memory lane. I went back to 73, 75 when I was a student of K.S. Mani, and I filled the forms of PL480 scheme on epilepsy. And, right then, his nephew, Kalyan Sundaram, was my batchmate. And Kalyan Sundaram showed me the Lord Brain's textbook of neurology on the chapter of epilepsy, where K.S. Mani et al. Used to come. And, we were so proud seeing an Indian name in Lord's textbook. It's like going to Madame Tussauds Museum, and you stand next to an Indian, with a wax. We were so proud. It sort of gave us gooseberries, to have K.S. Mani's name there. So you took me down the memory lane, and I'm really very happy that you have taken hot water epilepsy to a different level. We just heard of a diagnosis quoted, but you've gone, investigated, and you've now gone into really what's really happening there. Wonderful.
Thank you, sir. Thank you very much.
Last question. Right behind you.
I am Dr. Ramanujam. We have actually recorded 2 cases in our VHS about quite some time back, about 2 or 3 years back. And the more than that, the actual relationship of the heat to the body, that is, why not at higher temperature, that is in summer. In summer, there is a high temperature, so they can easily go in for a heat stroke and seizures. Like that, is there any relationship between the hot weather and the...
I have looked at all these things in my beginning of my career. The temperature, the hot zones, whether it is in Middle East countries. I even looked at from the people from the Middle East countries. And I should not say in an open meeting, but it is, I have to mention because you raised this question, it is more common among the Muslims than about the Hindus. And it has been reported, I have published that also in the beginning. So I wanted to look at what is happening in there, anywhere in the Middle East countries, whether it is there. It is there in Japan. It is there now in large number of cases have been reported now from Turkey. And I get my friend Bibek, is his name, and they are publishing one after another, and I'm seeing these cases. Because all these reports comes to me for the review. So I'm seeing that large number of Turkey is there. Whether it is missed out in other parts of the country is still a question. And I had I don't know whether I have crossing my time, I had a very, very interesting case which went into a legal aspect. One of the Indian Institute of Science professor who was from Bangalore went to US, and in US he was taking the bath and his family was not there on that day. It was on a weekend and he took the bath, and Monday morning he did not report for work. And when they did not report for work, they were looking what is the reason why he has not come. Then there was no answer, repeated phone calls. This is a fact, it is not a story. And then afterwards, then somebody broke open the door and saw that this man was taking a bath and had dead there. And then they didn't know what is to be done. So naturally, autopsy was done. When autopsy was done, in the viscera, the sodium valproate was seen. And then because sodium valproate was seen, they assumed that this was an epilepsy. They went back to the doctor and then found out the history. You know that in US, you can get everything. That doctor said, yes, this man used to come and tell me that he used to get on hot water bath. Whenever he takes hot water bath, he used to get a seizure. And the tablet I was giving was valproate. Then they looked at the literature. Because they found my name, they sent all the legal papers to me. And afterwards, it was confirmed that it was nothing but a hot water epilepsy, and unfortunately, he died. But his wife came to me saying that these people have not read. This could have been easily been prevented by taking benzodiazepines. And that was the literature. So what it means is that this is there everywhere. But in some parts, it is much more common. And genetics is playing a role. But now we know it is an epigenetic phenomena. That means gene and environmental interaction which is causing this type of epilepsy. Whether some factors of environment in a susceptible individual is producing the seizure is a question which we need to explore. But unfortunately, the environmental factors are not easy to find. It is very, very difficult. So one need to take it up further. Thank you.
Thank you.
Just one moment. We have the pleasure of having not one, but to my knowledge, two IMA branch chairmen here, both Dr. Prem Kumar Satya and Dr. Ramanujam. Request you to come up and honor Professor Satish Chandra on all our behalves. So we've had two high-power talks. One, all the technology for diagnosing autonomic dysfunction. Other, the wonderful work from lab to the clinic about hot water epilepsy. Both of these make India proud in different ways. Now I bring you back to the land of the bullock cart on how we look after our patients and some new ideas that we have been experimenting with here in Chennai. Just to remind you that we have a growing burden of elderly in India. And currently we think there are 125 million elderly in India. By 2026, we expect that number to be 173 million. So it's a very significant number of older people that we have. And of course, do older people have autonomic function problems? Yes is the answer. We don't have the prevalence of autonomic dysfunction, clinical autonomic dysfunction. But if you look at two particular conditions where it is a big part of, look at diabetes. The International Consensus Toronto panel report said that 20% of all people with diabetes have clinical autonomic dysfunction. Now this, of course, makes it a very big public health problem because we have one privilege, which is that we are the diabetes capital of the world. So we need to think about this. And of course, in Parkinson's disease, in surveys, 50% of 140 people with Parkinson's disease surveyed had clinical autonomic dysfunction. And as you know, Parkinson's disease, while not an extremely common disease, is a very important neurological disorder of the elderly. And if you then pass on to look at people with cardiac conditions, gastrointestinal conditions, you name it, autonomic dysfunction is perhaps a very important part of all those conditions. We don't ask for it, we don't measure it, we don't try to evaluate it because it's the silent nervous system and we are also silent about it in our minds. We've not been thinking so much about it, which is one reason why we organized today's symposium. Now, non-pharmacological therapy is obviously important because for two reasons. One is drugs are costly. Second, in people who are already getting older, it's very hard to go on and on prescribing newer and newer drugs. So we must think of other ways of getting people better. Education is obviously very important. Teaching people about the pathophysiology, teaching people about the prognosis of autonomic dysfunction is extremely important. Water, as Professor Matthias told you, 2 glasses he showed you. So more water is very important for people with orthostatic hypotension or people with vasovagal syncope. Important to remember. Exercise training is shown to increase blood volume and to modulate baroreceptor function. So that's very important. Isometric muscular contractions, you'll probably see this in his oration, but there are particular postures that people can take. For example, this compresses the muscles and provides additional cardiac output. So that is very important for treating orthostatic hypotension. It's important for treating vasovagal syncope. Tilt training is very important, and places where tilt training is available, it can be done. It requires people to go to hospital. It requires that the hospital has the equipment. In Chennai, I only know of 1 or 2 places that have the equipment, even to do testing, let alone do treatment. So that is something that we have to keep in mind. And of course, compression of the abdomen and compression of the abdomen and legs using tight stockings, something like what we do for varicose veins, is thought to be helpful in terms of returning greater cardiac output and therefore preventing orthostatic hypotension. Let me take you to another thought process. As like you, I'm a physician, like most of you. I've sat across tables, used couches to examine patients. I have prescribed for them. I've carried out tests in them. But over a period of time, I've also understood that there's only so much I'm able to offer them. I can modulate their medication. I can give them suggestions. But there's very little I can do to make them follow my suggestions, point number 1. There's also very little I can do personally to get them back to health, apart from prescribing and suggesting that so many things ought to be done. This is where the whole idea of comprehensive care comes into play. It's 360-degree care, which is aimed at people with chronic disease. And this is something that Professor Satish Chandra will agree. We've experienced, for example, with conditions like epilepsy, where a whole team looks after the patient, not just the doctor alone. This is applicable for a range of neurological disorders, a range of general medical conditions. In fact, any chronic disease will benefit from comprehensive care because certain aspects of the disease are not going to go away and people need to be rehabilitated. Introducing it early on in the course of an illness, taking it from hospital to clinic to home, all these things are extremely important and we need to think about it. And in neurological disorders, comprehensive care is very important because most patients with a neurological disease are left with either static disability, I've had a stroke, I'm left with residual hemiplegia, I'm left with residual difficulties in speaking and so on and so forth, or with progressive disability. For example, very few people go through Parkinson's disease without becoming more and more and more disabled. It's true for many other conditions. Disability is a big part of diabetes as the complications develop. Disability is a big part of heart disease as people find it difficult even to climb one flight of stairs over a period of time. Disability is a big part of many medical conditions, and we ought to think about it therefore. And what we felt needed to be done was to bring under one roof a host of treatments. In the old days, we started off by bringing together physiotherapy and counseling and nutrition along with the doctor under one roof. Then I started getting patients who would come and tell me, because I practice both neurology and psychiatry, they'll come and tell me, oh, you know, I went and did this 21-day Ayurveda program and I am feeling so much better. Okay. Or they would come and say, I started doing yoga and ever since I started doing yoga, I am feeling so much better. And in the beginning, I thought to myself, I think which most of us do, since we don't understand this, is, oh, some mumbo jumbo and the fellow's fallen for it. And this was the thought process that used to go through my mind. Later, I started thinking that maybe there is some truth in this. Maybe there is some benefit that people are getting out of these treatments. And which is when we started looking at it a little more carefully. And our first experiment was to start a primary care clinic, put in a family physician, physiotherapy, counseling, and put in an Ayurveda room with Ayurveda therapies. And this we did about 5 years ago now as a pilot project. In fact, it was all so unplanned that I just rented a house near my own home. I had whatever spare money I had in my bank, I used it to just set it up. I didn't even think how am I going to pay next month's salary. So it was completely not thought about at all. What was interesting in that pilot project was that over a year it became very clear nobody in that area will come and see the doctor we've put there. For the simple reason they have their own doctor who may be 10 kilometers away, but they want to go see their own doctor. Nobody in that area will use the clinic for anything else, but they will all use it for therapy. They will come and say, oh, I'd like to have a massage, or I will take physiotherapy with you. My daughter needs counseling, and so on and so forth. Can I see the dietitian? That people are willing to use it for. This was the lesson that we learned very early on. And that was what led us to develop these TriMed centers. Over a period of time, what we have done is to bring many treatments under one umbrella and to put, like in medicine, we have best practice models, we have protocols. We have basically put process to what we do. And we have protocols with which we work. I won't dwell on this because of shortage of time, but just to say that the whole field of complementary and alternative medicine is not that uncommon. The problem in our country, like many things, it's unregulated, but it's not uncommon. The second thing I want to say to you is that in the United States of America, today there are 15 departments of integrative medicine in universities. So we are talking about university departments that have been started to research integrative medicine. So it's quite interesting that they are thinking ahead of us and they are using things that we actually have access to and we are not using. And I think that that is something that set me thinking when I went to the US last. We have a great tradition of mind-body medicine in India, in Ayurveda, which has been described as an extraordinary tradition with yogic spiritual traditions. And we have this, within that, we have this very unique, what today the West is trying to popularize. They're talking about personalized medicine. We've thought about personalized medicine for centuries. We've always looked at the individual. We've always looked at what is that individual's constitution, what is that individual's, what's right or wrong for that individual, what are that individual's habits, and then decided to look after that individual. So the West is talking about personalized medicine, which is a little bit designer in the sense that today personalized medicine means I'll also tell you your, what do you call it, your genome, what your genome looks like. So they're taking it to another level. But we've always had this tradition of personalized medicine in us. And we know also from the research that's available, I will not dwell on this, that the practice of yoga, for example, which is uniquely Indian, has got a number of benefits for the human body. it decreases cortisol levels, it stimulates your immune system, it controls blood pressure, it increases melatonin to promote sleep. So we know that the traditions that we have do a number of very good things for our patients, and it has the potential to help medical conditions like epilepsy or psychiatric disorders, stress, and so on and so forth. We know all this. Here is a VHS psychologist slide provided by Dr. Subbulakshmi doing a number of yogasanas. Again, due to paucity of time, I'm going to just move quickly through this. So when in TriMed, what we have tried to do, therefore, is to put together a process of 10 different treatments, all being available under one roof, all as support to allopathic medicine. So the family physician is at the fountainhead, and we have all the other doctors and all the other therapists working alongside the family physician to deliver care to a patient. So the team in every center includes, apart from the family physician, Ayurveda doctors, naturotherapy doctors who also practice yoga, physical therapists, counselors, a nutritionist who goes across the centers, and then we have male and female therapists who actually deliver the treatments. They use water, they use oil, they use mud, they use a number of substances. We put in a process. So what happens when you come in is you're seen by the whole team. That's part of our triage. They take about 3 hours to do this, and each person has an opinion about the client, that this is what is wrong with you. That opinion gets integrated into a kind of therapeutic program, which is then shared with the client. Every center works like a daycare hospital. So people are then given a prescription. Why don't you have the following treatments for X number of days by coming in every day? So people are not disrupted from their daily life. They don't have to go and stay in a hospital. And yet it's all happening under the umbrella of a family physician who understands medical science and medical process. And safety and quality, these things are very, very important to us. We address a number of medical specialties today, and we have programs that rehabilitate people from disability. We have programs that restore function, like for example, a frozen shoulder or a bad knee can be brought back to good function. And we have programs that just rejuvenate and make people feel better for those who prefer to have such treatments. So over 4 years, we've looked after over 4,000 patients. In the last year to 2014, we had 1,500 patients walk through our doors, which is not an inconsiderable number. Each patient took a median number of 9 treatments. So that's a fair number of treatments that have been delivered in a year's time. We've had 125 doctors share patients with us in this period, and many of you in this room perhaps have been part of that. And I'm very happy to say, and that makes me happiest always, 25 or 30 of those are doctors bringing themselves, their spouses, their parents, or their children or grandchildren. And that makes me very happy, because that to serve the medical profession and to have the trust in the medical profession is perhaps most important for any treatment. That's when it gets most rigorous, close look at by people who know something about what is being done. So multiple interventions with a focus that will improve activities of daily living and quality of life. And let me quickly share with you how we have used that in an older person with autonomic failure, which is relevant to the theme of the discussion today. So this is a 66-year-old school headmaster who comes from down south. He came with a complaint of frequent falls while standing, and he feels well as soon as he lies down. And this started in the middle of 2013. As a consequence, by the time we saw him, for 12 months, he was avoiding standing altogether. He was lying down most of the time. And you can imagine that confers a considerable amount of disability on any individual. If you can't stand up, you have trouble. He had a lot of body pain, he had trouble swallowing, and he was moderately dependent on his activities of daily living. He has had a history of generalized seizures in the past, which were under control with treatment. He also had a history of depression, which was controlled with treatment. He had been put on thyroidazine by his GP many, many years ago, and who had advised him not to go off it because he was worried that he would relapse. So he continued to take thyroidazine for years and years and years. On examination, he had normal higher functions. His speech when he came was slurred. He was unable to stand due to severe giddiness. And when we took the BP, lying down was 100 by 80. Standing, systolic was 50, diastolic could not be recorded. So no wonder he could not stand. It was very, very obvious that this was an individual who was going to have great difficulty standing. He had no focal neurological deficits apart from the extrapyramidal symptoms and a little bit of stiffness that I was talking about, limb rigidity I was talking about. He had been extensively evaluated by a cardiologist who's got an autonomic lab and was confirmed as having severe autonomic dysfunction. Okay. He was prescribed midodrine by the cardiologist, which is, according to Professor Matthias, level 2. We start with fludrocortisone to improve the blood pressure in somebody with orthostatic hypotension. Midodrine is thought to be level 2. So in case fludrocortisone doesn't work, then you move to midodrine. It's quite expensive, I'm told. It's also not available in a number of places, I'm told. He was on levodopa, controlled release, oxcarbazepine, extended release, the old prescription of thyroidazine, and of course he was on clobazam, frisium, which Professor Satish Chandra has talked about, to prevent his seizures. What we offered him, first in hospital, because this was a man who couldn't stand up. There's no point bringing him to a day clinic. So first in hospital, then at home, and then finally in the day center, was a physiotherapy program that included electrotherapy, passive mobilization, postural exercises, gait and balance training, and then finally active exercises. So he was slowly taken from exercises lying down to exercises standing up and taught how to stand up safely. He had acupuncture with very specific parts involved. He had a mud pack because of his GI dysfunction and his pain. He also received relaxation exercises and some motivational counseling, because people lose confidence once they lie down and they need confidence to get back on their feet. One of the reasons why a lot of our patients stay lying down or on wheelchairs is because they don't have the confidence to walk. It's very important to bring back that confidence. With treatment, pain subsided, stiffness reduced. He was able to walk for about half an hour. He's able to walk and climb stairs independently now. His BP has also improved. And I think what we'll try and do is show you a video, if this will play. What audio?
Okay? From sitting to standing.
Thanks.
So, உட்கார்ந்து எழுதுறீங்க பாருங்க, எப்படி எழுதுவீங்க? Stand up. எழுதுறீங்க. நிமிர்ந்து எழுதுங்க பார்க்கலாம். கையை எடுத்து நிமிர்ந்து எழுதுங்க. Stand straight. முட்டி நிமிர்ந்துக்கோங்க. ஓகே, மெதுவா உட்காருங்க.
So as you can see, he is gone from lying flat on his back, which we don't have a video of and which is not particularly exciting to show anyway, to standing with difficulty and support, and finally now walking and climbing stairs, obviously with somebody supporting him a little bit, but on the other hand, it's a huge change for him. So I was very pleasantly surprised to see him walk into my room 1 year later, being quite mobile. In fact, 6 months later, being quite mobile and being able to do a lot of his activities of daily living. This is therefore somebody with autonomic dysfunction, severe orthostatic hypotension, who has improved with both midodrine and therapy. Now, did midodrine get him better? Did therapy get him better? It's the million-dollar question. But I have one conviction in me: if he had just given him the medicine, he wouldn't have developed the confidence to walk. And I think that what is very, very important, therefore, is that we do consider combining non-pharmacological approaches with pharmacological approaches. So our way is modern medicine-led. It's comprehensive. It incorporates the richness of many traditions, and we look at improving quality of life and improving activities of daily living. If you wish to talk to any of our staff members, we have a few people here who will be outside, and they'll be very happy to share their experiences with you. When we reviewed our outcomes, 95% of people with taking these type of treatments actually get better. It's only about 5% who report no change from the time that they start a treatment. And we feel, therefore, that there is great potential for modern medicine practitioners to leverage on what exists in our own tradition. And my wish is that this should not become one other case where, like Basmati, somebody in the US patents it. You know, you will find that Ayurveda and yoga has been patented by somebody in the US, and then you have to pay them in order to use it. It's not a very nice thought. So I would think that all of us should take an interest about what is possible in our own system. Let me leave you with Peter Drucker, who famously said, the best way to predict the future is to create it. We have older people, a growing burden. We have to help them. And with our pills and with our surgeries alone, I don't think we can do it. We need to do much more. And I think comprehensive care is perhaps going to be one of the answers. I will not say it's the only answer or the most important answer, but certainly one of the answers. Thank you so much. We will all get on stage now to have a photograph taken. So I request everyone to kind of not leave the room immediately. They're going to try and get us all together on stage. We need a few chairs back on stage. If there are one or two questions, I'm happy to take it while they're doing that. Is Matthias there? Yes. So Matthias there?
I wanted to know whether in your Ayurvedic team, you have anyone who has specialized in Varmakalai. Because I had a personal experience of having some problem, and I went through physiotherapy. They said you had to do surgery to loosen the tendons. And someone with the Varma who used to come home and did it, in 4 settings, I'm fine now.
Dr. Deenadayalan here? Does anybody in the team do Varma?
Well, I'm Dr. Deenadayalan from TriMed Center. Yes, we have therapists who are trained in doing Varmakalai, but professionally, Varmakalai is more trained by Siddha physicians. We have a part of Varmakalai program, which is being not done in a very intensive phase, but we do train therapists under the guidance of an Ayurveda physician to do Varmakalai.
I'm Dr. George. Those who had a stroke, elderly people, apart from physiotherapy, is there any other alternative?
So post-stroke, there are a number of things that we can do. In fact, one of our stellar cases is rehabilitating somebody 1 year post-stroke who had actually been in bed for a whole year. And he got to walk. We have a video of the entire process. There's plenty that we can do post-stroke. One of the things that happens is that people have to relearn to use function. And while physiotherapy is a very important and competent field, there are other treatments that can, also be extremely useful. To give you an example, muscle spasm responds very well to therapeutic massage, whether it comes from an Ayurveda space or a naturotherapy space, much better than it does to electrotherapy. So there are things that we can do in combination which help. Similarly, yoga is all about posture and balance, and there's much that we can use those principles for. So I think the answer is yes. In terms of rehabilitating people, there is a lot that we can do when we bring these traditions in. They all have potential. My concern is always that if you go to a solo practitioner, my patients, the experience I've had is they're told, oh, stop all your medicines, we're going to treat you. And then, of course, all hell breaks loose because the well-controlled sugar is no longer well-controlled, well-controlled epilepsy is no longer well-controlled. So that worries me greatly, which is one reason why I personally feel an organized system of practice is extremely important. And an organized system can actually have a lot of impact if we plan it and organize it properly. I think in paucity of time, happy to continue the conversation outside. Can I request people to come for the photograph? Professor Satish Chandra to the middle, please. I request the senior doctors to take a seat. So you have to qualify for this, you have to consider yourself senior.